Welcome to this rapid high-yield explainer. Today, we're diving into a clinical case study that literally traps even seasoned medicos on the wards. We're talking about the geriatric anticholinergic burden. It's a silent, highly dangerous systemic issue that presents as a very common yet totally misleading set of symptoms. If you've ever been on a night shift and faced an elderly patient with sudden confusion, this explainer is going to completely change how you approach their care. Okay, let's get into it. Here's a quick look at our roadmap for today's case. We'll start with the clinical dilemma, navigate the iatrogenic cascade trap, unmask the anticholinergic toxidrome, look at some safer alternatives and reversal protocols, and wrap up with high-yield clinical takeaways. Section 1, the clinical dilemma. Let's look at the baseline risk factors. In geriatric medicine, the history is everything, right? And honestly, the most vital piece of history usually sits right on the patient's nightstand. Take a look at Mrs. Sharma's pill box. The sheer volume of pharmacology at play here is striking. She's on amlodipine and Antinol for hypertension, metformin for type 2 diabetes, and ranitidine for GERD. But check out that highly risky combination at the bottom. We've got oxybutynin prescribed for an overactive bladder and promethazine taken at night for sleep. Now, on their own in a younger patient, may be manageable. But together in a geriatric patient, this is basically a chemical collision waiting to happen. So, time for a quick clinical decision. Mrs. Sharma is brought in by her family, presenting with acute new-onset confusion and urinary retention. Faced with this specific presentation in an elderly patient, what is your immediate diagnostic reflex? Think about it for a second, because your next move dictates whether she gets better tonight or ends up staying in the hospital for 2 weeks. Here are your typical options. Do you go with option A, suspect a UTI, place a catheter, and start empirical antibiotics? How about option B, suspect a toxidrome and immediately stop the oxybutynin and promethazine? Or maybe option C, suspect an acute stroke due to her age and confusion, and order an immediate CT of the brain. It is absolutely crucial here to look past the obvious urinary symptoms. The most common reflex on the ward is option A, but as you'll see, that is actually a massive mistake. Moving to part 2, the iatrogenic cascade trap. Let's explore why jumping to that most common assumption, a UTI, is a severe medical pitfall. If you chose option A, you've just triggered the iatrogenic cascade. Here's how it plays out. Step 1, you treat the symptom by placing a Foley catheter to relieve the urinary retention. Step 2, you cause iatrogenic harm. That catheter introduces a massive infection risk into a vulnerable elderly patient, which then triggers unnecessary broad-spectrum antibiotics, adding even more to her drug burden. And step 3, persistent pathology. Because you treated a side effect with an invasive procedure, the root cause, that chemical collision we saw earlier, is completely missed. Her confusion is not going to resolve. So the golden rule here is never treat a medication side effect with the procedure without reviewing the chart first. Section 3, Anticholinergic toxidrome unmasked. Let's see what's actually happening in her body. To really solve this case correctly, we have to uncover the true pathophysiology. The correct diagnosis here is systemic muscarinic blockade. This is a classic textbook manifestation of an anticholinergic toxidrome. We're looking at delirium and acute confusion in the brain, we see blurred vision and a dry mouth, in the heart we find tachycardia, and in the GI and renal systems, severe constipation and urinary retention, which perfectly explains her presentation. Her urinary retention wasn't the cause of her confusion via a UTI. Actually, both the retention and the confusion are parallel symptoms of the exact same chemical blockade. In geriatric pharmacology, there's a very specific number you need to burn into your memory, the number 3. This is your red line. Exceeding a cumulative score of 3 across a patient's medication list means guaranteed symptomatic toxicity. Let's look at the anticholinergic burden, or ACB score, to see exactly how we hit that red line. Drugs are rated from 1, being weak anticholinergic activity, to 3, being high. When we calculate Mrs. Sharma's total, her oxybutynin is a moderate risk, contributing a 2. Her promethazine is a high risk, adding a 3. That puts her at a highly toxic cumulative score of 5. The dial is completely in the red, guys. This proves her presentation is purely pharmacological. Section 4, safer alternatives and reversal. Now that we've got our definitive diagnosis, it's time to write the orders to clear this chemical blockade safely. We need to swap out the dangers for the solutions. First, we must immediately swap the non-selective M3 blocker, oxybutynin, for Mirabegron. Mirabegron is a real game changer here. It's a beta-3 agonist that wonderfully relaxes the bladder without any acetylcholine blockade whatsoever. It bypasses the muscarinic receptors entirely. Next up, we switch out that high-risk promethazine for melatonin at 3 milligrams for sleep. Melatonin provides non-anticholinergic sleep regulation. You get the desired clinical effects without adding a single point to the ACB score. To manage her acute state, you're going to execute this 4-step reversal protocol. Steps 1 and 2, immediately discontinue the offending agents. Stop the oxybutynin and promethazine. Step 3, administer IV fluids to hydrate and help wash out that anticholinergic load faster. And Step 4, monitor the patient. You can expect her cognition to clear and her delirium to resolve over the next 24 to 48 hours, as the toxidrome simply washes out of her system. No catheter required, no antibiotics needed. And finally, Section 5, high-yield clinical takeaways. Let's bridge this word solution to the academic frameworks you absolutely need for your board exams and daily practice. The global standard for potentially inappropriate medication use in older adults is the AGS Beers Criteria. This text establishes a golden rule: avoid prescribing multiple anticholinergic drugs simultaneously. It actually goes further, recommending the routine, mandatory use of ACB calculators for any patient over 65 who presents with new-onset acute confusion or delirium. It should literally be as routine as checking a pulse. If you're prepping for your NEET PG exams or honestly any medical board exam, memorize these high-yield one-liners. First, an ACB score greater than 3 in the elderly is always a red flag in exam stems. Second, Mirabegron is a highly tested answer as the safest overactive bladder drug in the elderly. Third, oxybutynin plus any antihistamine is the classic setup for a toxidrome scenario. And lastly, and this is a big one, note that the correct answer to this exact clinical stem is cumulative anticholinergic toxicity, not cholinergic excess. Don't let the exam writers trick you on the mechanism there. So the absolute takeaway rule to anchor in your mind today is to always calculate the anticholinergic burden before adding any new drug to an elderly patient's chart. I'm curious, did you fall for the UTI trap at the beginning? Hey, it happens to the best of us, but now you've got the tools to spot it. Make sure you're ready for our next Anticholinergic 24 case explainer, where we'll be breaking down a massive bleed scenario involving the dangerous interaction between NSAIDs and warfarin. Until then, remember, in geriatric medicine, the most dangerous thing we do is often the next prescription we write. Keep your diagnostics sharp and your drug burdens low.